Okay, well, I think since it's a little bit past the hour, we're going to get started. I want to welcome everyone to the Washington State Telehealth Collaborative. Thanks for hosting us, Melina. For those who are on video and phone, you're missing out on a lovely conference room, very nice technology here and a beautiful setting. So I really wanted to extend my thank yous to Whitney and Dr. Guff and your team here. So
thank you.
Thanks so much.
Thanks for coming.
What we're going to do is to start with introductions and start with folks in the room here, and then we'll go to video and then we'll go to the phone. So Whitney, do you want to kind of start things off and just do a brief hello and who you are?
Oh, sure. Hello, I'm Whitney Howard, and I work as the Director of Fully Integrated Managed Care for Molina, and I've been working with Dr. Goff on a lot of our telehealth initiatives with some of our contracting strategies.
Megan Gillis, I'm in provider contracting here at Molina and with Whitney.
Ricardo Jimenez, CMO, Seymour Community Health Centers.
Joelle Fati, nurse practitioner at Swedish Medical Center, and I oversee telehealth clinics.
Brody DeChinko, GM of Convenient Care for Cambia Health Solutions / Regents.
Sheila Green-Schick, representing Washington State Information Management Association. I also Virginia Stroud, multi-care health system.
Priscilla.
Oh, I'm Priscilla, University of Washington.
John Scott, University of Washington.
Chris Cable, I'm Medical Director with Kaiser Permanente, Washington.
I'm Dr. Tricia Auerbach. I'm Senior Medical Director here at Molina. I'm covering for Dr. Goff. She's not on the phone today. Her family should be here.
Thanks. And maybe if we can go to the video, starting with Cara Towle.
Hi, I'm Cara. I'm in the Department of Psychiatry at the University of Washington, Associate Director for two programs, the Psychiatry Consultation and Telepsychiatry Program, as well as the Integrated Care Training Program.
Great. Thanks, Cara. And then Sue Stern, I see maybe your desktop or the floor. Sue, do you want to say hello?
Hi, how are you? I am Susan Stern. I'm representing Washington American College of Emergency Physicians. I'm an emergency medicine at Harborview and the University of Washington Medical Center.
Great, thanks, Sue. I think we had Mary Kempfe also on video. Mary, do you want to say hello and introduce yourself and where you're from? And you might just need to unmute yourself. If you haven't used this before, it's in the lower left. I'm not sure. I don't have a video on you, Mary. So, do you want to say hello, Mary? I think we might have you live now. Oh, she doesn't have a mic. Okay, great. Mary, if you could just type in through the chat where you're from, that'd be great. It's just for the folks who are maybe joining for the first time, if you don't have a microphone, there is a chat function. And Mary is from Labor and Industries here at the state, so thanks for joining. Let's go to the phone next. And I think we had Rod from Virginia Mason. Rod, do you want to introduce yourself?
Ross, ROSS Baker from Virginia Mason.
Great. And then Gwen O'Keefe.
Hi, I'm an independent consultant from Go Healthcare Strategy.
Great. We've got a couple other call-in numbers. So I see a couple of 206 numbers. If you are calling in, please introduce yourself.
I'm Scott Kennedy, Chief Medical Officer at Olympic Medical Center in Port Angeles and Sequim.
Great. Thanks, Scott, for joining us.
Great.
Thank you.
Anyone else on the phone? I think we got a couple others I can see.
Mark Lowe from Seattle Children's. This is Mark Lowe, a medical director for telehealth Seattle Children's.
Okay, Mark Ho from Seattle Children's. Did I hear that correctly?
Yeah, Mark Lowe.
Great, thanks, Mark, for joining. And Mark, is Dr. Del Baccaro also on the line with you?
He's not with me on the phone. I don't know if he's calling in later.
Okay, all right. Thanks for joining. And anyone else on the phone? I think we maybe have one or two more. All right. Well, good. So I think what we're going to do first is just review the minutes from February 10th. This is our meeting we had down in Olympia. We had so many people join in person. It was great. I appreciate everyone who made the drive down there. And for those of you who weren't able to join in person, you missed a very grand tour of the Capitol and the Senate floor. So that was really cool that both Senator Cleveland and Senator Becker were able to host us there.
Was that photo ever distributed?
You know, we have it, and when you come to UW in May, this is an incentive to come in person. We will give you those. She actually printed them up.
Oh, so we don't have a digital.
I'm holding them hostage.
I hope they'll be framed.
Yeah. But I don't know if we got the digital copy. That'd be fine if we get the digital, but we did get a hard copy. It's just
Yes.
So I guess the first thing to note is that we do have the new logo. If you see it on our minutes, to Brady and for everyone, I think it looks really cool, especially in the green, the evergreen color there. So you'll see that going forward, and I think we have added that to the website, if I'm not mistaken. So we did talk about the FAQ documents, and that is on our agenda to kind of come back and clean those up. And then we did have, starting the conversation on the e-consult store and forward technology, which we're going to wrap up. So see if there's any edits, additions that folks wanted to make our conversation last time.
Are you editing it right now?
If you would like me to.
So I was in attendance on the telephone, if that matters.
Well, goodness. I apologize.
Anything else that folks wanted to edit?
Invitations are great, by the way.
Yeah. Did everyone get the slides?
Yes.
Yeah, okay, great. All right. So we're just getting started. I heard a couple other people joining by phone. If you join by phone and haven't introduced yourself, can you please take this opportunity to say hello?
This is Julie Sylvester from Virginia Mason Medical Center.
Hi, Julie. Thanks for joining. Can you hear us?
Oh, I can hear you guys perfectly.
Good. We've got two microphones today, so that's great. Anyone else who just joined by phone? Okay, maybe it was just Julie then. Well, good. So the next thing I wanted to do is maybe finish up our conversation that we were having about e-consult, and what I'm going to do next is turn it over to you, Chris.
Sure.
And then I have a little bit to go there, so I'm going to share my screen. I'll let you drive. It's just your, so is this going to be kind of a standard slideshow?
Great. Okay, thank you. All right. So yeah, I was asked by John to talk a little about the e-consult experience within group health, which, as you can see from slide one, goes back some years. So we started with what's really an analogous thing for e-consult. E-consults, in my mind now, is a very specific tool in Epic. But at 2009, there was no such thing. So we created our own thing, which is what I'll walk through initially. We called a virtual consult. So that we're transitioning from one to the other now as a tool, but I think the concepts and outcomes are probably very similar. So as a start for us, when we talk about virtual consults, what does that mean? So we view that as being a documentable encounter with recommendations by a specialist. This is, we think, an alternative to a face-to-face visit. It needs to rise to that level before we would think something is a valid virtual consult. And for us, it's a way to kind of make both documented and then searchable these interactions. So prior to virtual consults, we've been providing really for years the group health specialty consultation from afar by phone or through secure message or something, but there's no record in the EMR around that. And so that was initially the problem we were trying to solve, was just to demonstrate that because it's valuable clinical care, but it gets lost immediately when it's not recorded. So as we thought about it, we thought, well, let's try to distinguish between the concept of a virtual curbside and virtual consult. So our very simple litmus test is a curbside is sort of patient independent. So if you have a general question of a specialist, like the one here, what's the best antiplatelet stroke prevention? That's sort of a general knowledge question. There's no virtual consult you would make from that. But if it's about a specific patient or you have to open the record and really understand something about them, then that's what we would call a virtual consult. So a pretty simple definition. So when we built these, and I'll run through this part a little bit quickly because it's sort of processy, but just to show how we built the process initially was we took a telephone encounter in Epic and our IT team mutated it into a virtual consult, which we built as a homegrown thing. And it would start, as you can see, with a referral to a specialty pool. In this case, it's the neurology pool. And you would just simply type a message. So it was really built out of our secure message functionality, which I think is important when I share our initial outcomes. Because it was pretty loose. Again, our goal was really to document the thinking and care that was going on more than to really think about reimbursement or billing or things like that a little further down the road. So we left it really wide open that it would be initiated just through a secure message process. And then the receiving specialist could make the call and they could decide themselves to just rise to the level of virtual consult. Did I invest enough time and energy and have to go into the chart? And is this something that really feels like it needs that litmus test I defined earlier on virtual consult? So if they felt that was the case, they could transform the stat message into a virtual consult with the click of a button, basically in our Epic system. And so the screenshot shows what that would look like. And then this was, again, the main goal we were after was this would then show up later in chart reviews. So we had these very easy to find virtual consults that you could look back years later and see when, in this case, Dr. Sears had written about this patient's neurology condition. So that was most of the problem we were trying to solve. And then the closing the loop, it would flow back into the ordering where the primary care provider's in basket. And again, because this is under the hood, actually a telephone encounter, it would weirdly show up in the patient call box. And we just, sort of, within our organization and culture, that's where virtual consults show up because we had crafted this on our own when Epic was really not yet making these kinds of things. So we did try to think about, once we had set it up and running, how often is it used? What's the overall impact of that? So this is very early data. You can see it goes back to 2010, right when we had kicked off the virtual consults. And as you probably see even now, there's a lot of variability by specialty in who uses these things. So I think no surprise, we got a lot from endocrinology. We got a lot from nephrology. A little surprised, we got a lot from cardiology. That was not something we would have expected. And then no surprise, not a lot from the surgical specialties. So probably a pretty typical distribution I think you would see now even 7 years later for how these things are used. And what we tried to do was correlate that with access. So within group health, the way we've been built and modeled, admittedly, we don't have a whole lot of really detailed accuracy around cost per visit. It could be no surprise to anybody that's not our kind of business focus. We focus more on functional outcomes like access. So we tried to correlate the virtual care project with improvements in access and wait times and decreasing backlog and so forth, rather than cost as an outcome. And so this was really just correlation kind of data, early data. And if you see where there's a significant p-value, at least those couple ologies where there was good uptake for virtual consults, specifically endocrinology and nephrology, we seem to see a reduction in wait time for clinic visits, at least out the gate. However, over time, that kind of washed out, unfortunately. So this is a look at the blue line is the number of face-to-face visits, in this case, endocrinology. And the red line is the creation of virtual consults. And you can see August 2010, when we turned them on, they rapidly rocketed up and really not much change in that blue line. I mean, the face-to-face referral demand pretty much steady, unfortunately. And so we didn't see a lot of exchange that we were hoping to see, where face-to-face referrals were transformed into these virtual consults. And I think in retrospect, that's probably because of the way, again, we built it, very loose at the beginning. This was a very PRN specialist sort of activity. A specialist would get a secure message and then decide on the back end they wanted to turn this into a virtual consult. This was not tied to a referral order or anything as discrete as that. So I think not surprisingly, this is what we ended up getting. And I think rather than brand new demand, I think this is probably more a case of recognizing existing work. So I think if we had virtual consults back in 2009, these red lines would march back to 2008, 2007. I think this is work which had been going on under the hood for quite a while, and mostly we were just making it visible. And so I think, in my opinion, that's what this graphic really shows, is just bringing that background work into light.
Just a quick question. I can't
Yeah.
see the scale on the
left.
So is the blue line and the red bars, are those same scale as far as numbers, or?
They're slightly different. They're only different by a matter of about 50, so they're pretty close.
So on the left, it's virtual.
Left is virtual, right is referrals. Top left goes to 350, right goes to 250.
Okay, so you're mapping out the virtual consult in person.
Yep.
So Chris, one question. This is available. It's not a non-reimbursable activity, right?
Yeah, then certainly in
The second,
2010.
this didn't count towards productivity for the specialist.
I'll go through how we ended up doing that eventually. So at the time, no, we did not incorporate into any productivity model. We just put it out there. Again, the concept was to capture work already being done and to get better clinical documentation to capture the value that
I was thinking
already
about
happening.
mostly to justify that the work might have done, the impact might have gone to the patient, but especially needed to make it count.
Yep.
And so they allowed the visit, not necessarily, you know what I'm trying to get at.
Yep. And we had those long conversations with our specialists as well. And I think at least at the outset, this was, again, an advantage and a disadvantage to our opening process, was we left it very loose. We left it absolutely up to the specialist. They could decide if it was worth their 5 or 10 minutes to create a virtual consult. And my simple ask for them was, if you feel like whatever you decided clinically is important enough that 4 years from now you want someone to know it, make a virtual consult, write it down, because your care matters and you want people to know what you did. Or if it just took enough time that you spent 30 minutes digging into a chart and you want some kind of recognition for the effort, make a virtual consult. If either of those two reasons are true, you should do it. But there was no mandate, there was no real expectation. We kind of put it out there and let it go organically.
Do you know how much you captured? How much of the activity you think is going on you're actually capturing in?
Yeah, I would say at this stage, honestly, some less than majority fraction. I don't know, a swag 25% or something like that. And I base that mostly because you would see within a specialty a lot of variability. So Dr. Sears, he was one of our champions, and he would and still does tons of virtual referrals. And yet in his very own department, Dr. X would do none. And so probably not a difference in activity, probably a difference in desiring to write it down. And we still see some of that today. A distribution within a department for the virtual work, at least what's documented.
Chris, I just have a question about the total number of consults over that 5-year, or was it, maybe about 3-year time period. Would there be an expectation that actually it would be going up? Because I know in general, the overall trend in healthcare is that we're going to see
That was
more
my
and more.
question, is does this temporize, even though it may not have made a dramatic change, is it temporizing the
Right.
expected growth rate?
Right, that's what I'm saying.
Yeah. I think I would have to correlate that with our growth in group health at that time, and I can't recall if 10 to 13 was a year of flat growth or actual growth. We've had both. So I'd have to go back to answer that question. I don't know.
And I think it still may be pretty valuable if that is the case, if you're able to pull that data in that way.
Right.
Okay, but 5 years from now, we
that's
don't
true.
need 3 more endocrinologists. We just need this tool in place.
And for us, this would ideally be normalized by enrollment, and that would help see what's going on.
Catches my eye, though. I'm not sure whether it should have or not, but I mean, even independent of the replacement or lack of replacement, I mean, it's interesting to me how the curves actually have basically the same shape. Like they almost like an overlay, like when that little in the middle, it kind of goes up the same, and then it's kind of coming down at the same. There's a few outliers, but there's more of a relationship between those than not.
Yeah, I can't explain that, but I hadn't noticed that before. But the demand seems to go in parallel, virtual and face-to-face. Yeah, I'm not sure. And again, it may be, if I'm without a theory, related to, again, that we let the specialists sort of decide what to do. And so I guess if you've got 50% more things coming at you, you can try to send more to virtual enrollment. So maybe that's why they balance to some degree. It's a guess.
So for the virtual visits, were the first visits to the specialty face-to-face and then subsequent ones virtual, or you could just see a new patient virtual?
You could, and again, well, this will matter as I go further in the presentation, but at this time, they were not linked to referral orders per se. So they typically were more in the staff message venue, and then that's how we typically would do these visit replacements, if you will, through staff messages. So goal one at this time was just to make that visible, which I think it did. So it did certainly accomplish that. We had lots of virtual consults suddenly on the chart that were not there before 2010. So this was sort of our conclusion, was that we think it was great to document the clinical care. We think it opens up a new channel for communication. There was some concern that, as you lower the activation energy, you get more reaction. And so maybe this is in some regards creating a little bit more demand because it's a lot easier now to create these interactions. And so it was unclear if this was really accomplishing that higher goal of replacing face-to-face visits with virtual care. And this is just a snapshot of more current data. This is our virtual consult volumes for all specialties per month. And you can see we've been stable for some years, 2,000 and 2,500 per month. So we do about 30,000 a year across all of our specialties for virtual consults. And we think the majority of those are probably face-to-face surrogates for the level of care that occurs. So I think this is the maybe more interesting question, how you can value them. So when we designed these, we decided to go with the time-based thinking. And so we simply broke them up into 10-minute chunks, you can see there, and said we're going to value these based on how much time the specialist estimates they spend for the interaction. That includes the chart research and the documentation and A to Z, everything. All in, how much time did it take for you to do this? And this is how we translate that. So one I think benefit that we have in group health is that we can choose to measure productivity through a couple ways, and a lot of our specialists are on new visits. And so we judge their productivity by how many new patients they're seeing in a given time frame. And so since the virtual consults ideally are replacing virtual new visits, what we did was we looked at a couple of our large groups and asked the question to say, well, if all of these people came in face-to-face, how many would have been a new visit? And so there's a couple exclusion criteria, if you will, for that. One would be, were they seen in the last 3 years? Because our definition of new visits follows Medicare, and if you've been seen in the last 2 years, we can't call you new, even if it's a new problem. So we took that cohort of patients who had virtual consults, and if they were seen in the previous 3 years within that specialty, you knock them out, you exclude them. The other question we said is, of that cohort, how many were seen face-to-face? And we arbitrarily picked 8 weeks, so within the next 8 weeks in the specialty. Because we would say, well, it seems like the virtual consult didn't work, right? You tried something, but you saw them face-to-face anyway, so you don't want to count a new visit twice. So if you were seen within... It got zeroed out. So that got excluded as well. So once we did that, we were left with a subset of visits that seems like, well, they were new, and it seems like there was a problem that was handled because we never saw them thereafter. And so that's plausibly a worthwhile visit. So the ratio varies, but some example here for our big groups, GI, orthopedics, cards, and pulmonary, it's about 25%. So that's the number we use. So for every 4 virtual consults you do, you would get 1 new visit credit, if you will. Going back to the time frame issue, we only credit virtual consults that take more than 10 minutes. We figure if it's taking less than 10 minutes, this is pretty trivial. Kind of hard to imagine that's a new visit replacement. But anything that's a virtual consult 20 or up, you get 25% credit, which we feel is sort of a functional parity for what the new visit credit would have been if this didn't exist. Endocrinology and neurology, different beasts, so much higher ratios. So they have a 50% success rate. I think the nature of the specialty, you can be more successful handling things virtually in those specialties. So we give them a different credit. So the upshot is we've got a sort of a unique specialty specific credit based on your particular mix and what your historical experience has been that would it feels fair, I guess, to the specialists. It gives again that functional parity. In addition, we give RVU credit, which matches the time duration. So back to these codes. If you did a VC30, it would be the same RVUs as if you had done a face-to-face visit and documented, greater than 30 minutes spent, 50% spent in counseling, and so on. That's the RVU equivalent we use. So we do both because some of our specialties do use RVUs as well, and we give them credit on both sides. So Any questions about that before we move on? Because I know that was a big area. All right. So how can they be improved? So we did realize back in 2013 that we were really not quite realizing that face-to-face. Was there a question? No. We weren't really getting that face-to-face exchange value that we were hoping to get. Again, phase one was about making things visible, which I think we did, but now we wanted to go further and say, how can we feel more confident that these are really replacing or being provided as an alternative to a face-to-face visit? So we built in the referral order, simply. So you can see there's an Epic referral order, and for a lot of our ologies now, a primary care doc can click virtual or office, and it's going to go down 2 different pathways. The end result for virtual will be what I showed you. You create a virtual consult, but we're trying to be more explicit around the entry point and making it a little less specialist prerogative. You know, I choose to make this virtual or not. So some outcomes related to that, you can see that's a little hard to see on a small screen, but that top impressive purple line, you can imagine what day we turned that on for endocrinology. So the endocrinology visits, doubled for virtual consults. That was when we turned on the new referral order. And maybe that lower arrow is showing some sort of early downtick in the face-to-face visits. Admittedly, the volumes aren't high. I think more impressive is the next slide. So this is our backlog. Again, what we look at as a big metric for our specialties. So endocrinology backlog, I don't have the arrow on here, but it basically correlates when that downslope starts to occur is when we turned on the virtual consult as part of the referral order. So I think more impressive than in 2009 where we didn't link them so tightly. And so I think that's a learning, I guess, to convey here is I think when you really build it into your referral process, you're more likely to see the true exchange of one for the other than what we did initially.
I'm just curious,
Yeah.
so if you have a backlog of patients and wait times, when you turn on your e-consult, you still have a finite or sort of a static state of providers. So are they taking extra time out of their day to do the e-consults to sort of backfill this need?
Yeah.
What does that look like?
I think it's because the e-consults are faster. So because it's asynchronous, because all the information is kind of there, you can get information, in my opinion. You can do it. So some of it is that. Some of it they do after hours for sure. And we see a lot of Epic work after hours. So a little bit of it is that. They take it home with them. They do it after hours. And some of it's just faster. So I think in a lot of cases, clinicians will maybe agree you can get what you want from the chart faster than talking to patients. Talking to patients takes a while, and it's important, but it's a slow part of the visit. When you have the virtual consult, all the information there for you, you can provide an opinion often a little more quickly. So I think they can do them a little faster is the upshot. So if you combine touches per day, face-to-face only or face-to-face and virtual, you're going to get more in the second case.
And no provider hesitancy in terms of like, whoa, I don't want to give my opinion. I don't know this patient. I haven't seen them and I'm documenting versus physician to physician talking on the phone, right?
Yeah.
Because ultimately the physician pulling the trigger is the one who's responsible for the plan and, the treatment.
Yep. So we still have some of that. And we have not mandated this to be done virtually. So when a primary care doc does that referral order and clicks virtual, we still view that as a recommendation. If the receiving specialist looks at it and says, nope, I think I should see them, that's totally fine. There's no disincentive, there's no penalty, there's no problem. We give specialists full leeway to decide if they want to see someone face-to-face.
Similar to that point, were you able to measure provider satisfaction on the primary care lens and on the specialty care lens before that turned on and a couple months after it turned on to see if there was an improvement or the opposite direction of their
Maybe
experience?
should have. No, we didn't. Honestly, we didn't look at that data. I'll be sharing
You
that.
do? Oh, okay, great.
I'll call this out as in sort of contradistinction. So this is oncology. Exact same thing happened. We turned on that virtual option for referrals, and you can see that's the lower purple. It basically nothing really changed. And again, I think it's the nature of the beast, right? It's a little hard to imagine a whole lot of virtual oncology referrals. We do get a lot for hematology, but for oncology, not so many. And so, as you would expect, not a lot of change. I mean, that small drop in backlog predates the virtual consult change. So again, I think the takeaway is it's still going to be specialty specific around the opportunity to convert face-to-face to virtual. And this is just the last little wrap-up slide. I mentioned that we, in 2009, created these virtual consults. Since then, Epic caught up. Epic has now got their own e-consults, which in a lot of ways are better. So we kind of describe there the from to. So it's one thing that my team is working on this year is we're going to formally switch from our revered but old virtual consult system to the e-consults in Epic. A big change for that, though, is going to be we're redesigning the workflow so that it will be much more inclusive of the patients. So the virtual consults was really still specialist to specialist, and the primary care doc would have to translate the specialist opinion, which usually meant copy and paste. But there would be that translation step, which feels not great to the patient. It feels like rework to the primary care doc. So we're going to go with e-consults and have them fully open in open notes, and we're going to have ticklers to patients so that you'll know that your endocrinologist is now writing an opinion. You can read it online. So we want to bring the patients more explicitly into the conversation. One special case of virtual consults I'll call out, and I tried to put in the slide deck, but I had some glitch and couldn't make it work. But teledermatology, so I view teledermatology as a special subset of virtual consults with a picture. And so probably 4 or 5 years ago, we turned on a teledermatology process. And in that case, we had gotten a little more clever in trying to measure things up front. And so we did get better data, which I had to share, but I can tell you the upshot was we did measure provider and patient satisfaction, and it was tons better with teledermatology because you went from a
4-month wait.
Right, from a 2 or 3 month wait to 2 days, exactly. And so we have a service expectation of a 4-hour turnaround for our teledermatology. That's from dermatologist to primary care. Now there's an extra delay from primary care back to the patient, so it's 2 days to the patient, but 4 hours from doc to doc.
I've used it in urgent care and it's wonderful. So I'm Melina, but I still do shifts. I used to work for group health.
Yeah.
In urgent care, you get it in 30 minutes.
It's really fast. Nice. Yeah. So the doc to doc turnaround, the service is great. And we did measure for those teledermatology interactions where the recommendation was given, how many people were subsequently seen in dermatology down the road. And we had about a 75% success rate, meaning the vast majority of visits stopped at that point. So advice was given, patient got care, and there was no need to be seen in dermatology. So our break-even point when we look at the time it takes to do that was about a 50% conversion rate, and so we beat that. And so we think that this actually is at an operational level more efficient and is a better use of our dermatologist time and a better experience for our providers and our patients. One other aspect with teledermatology that we found was it helps a lot with the triage. And so we did find about 7% of cases dermatologists wanted to see urgently, which is really important when you normally have a 2 or 3 month backlog. So being able to recognize those patients in the queue that, no, I need to see them tomorrow is immensely helpful. And we hadn't really anticipated that going in, but the dermatologists really view that as a win because it makes them feel more comfortable when you have such big backlogs.
Great. Maybe we can open it up for larger group discussions. First of all, I want to remind everyone, if you're not talking, please mute your microphone. We are hearing some people typing in the background, no doubt taking prolific notes on what we're talking about. And also, I know there's a couple of people who joined by phone. So if anyone has joined them and hasn't introduced themselves, I'd like you to do that now, and then we'll open it up for questions for Chris. Sure. Anyone from the phone who wants to say hello?
Emily Yu, Program Manager of Virtual Health at Multicare.
Hi, Emily.
Hi, this is
Anyone
Lisa
else?
Roach, the telehealth. Lisa Roach, telehealth billing and coding analyst for Providence.
Great, thanks, Lisa, for joining. Lori Wakashigi, are you on the phone? Okay, I know almost all our legislators are in session, so I'm not expecting it. Okay, any other questions for Chris?
What's the timeline that you've either already experienced or anticipate to experience with when you switched over to the Epic e-consults? Was that a 2-month project or a year-long project?
Yeah, so we haven't switched yet. We're going to pilot in a couple specialties, hopefully within the next 60 days. We'll start to switch that on, and my goal is by the end of the year to have it live for all specialties. We've been sort of tinkering with it for about a year.
Okay.
And it's been a real back burner project. We've had other things that have jumped to the front, especially with Kaiser permanente transition.
Just little things.
Yeah, so it kind of got parked for about a year. But in the background, our EPIC and our CMIO team have been working to try to find the best solution. I think we've actually crafted a really nice solution, because one problem with e-consults we have is how do you make sure the patient's involved in the discussion and determination? Because our primary care docs do a ton of work after hours or on the weekend. And so if you want to send a virtual or an e-consult to, oncology on Saturday, and then the patient gets a call on Monday morning saying, we'd like to see you in oncology face-to-face, and they haven't heard anything, that's really a problem.
Yeah. Right.
So we've thought about how to design workflows to, avoid or at least minimize that kind of thing. So hopefully we can share more in a few months. When we
So
can
about
go
a
live.
year lead time.
If we were
when it
working
wasn't high
actively on it, I
priority.
think it could be a 6-month
Yeah.
project if it was a front burner kind of thing. But it's been
Depends on your
percolating.
IT.
I'm sure, well, and the priority
Yeah.
list, yes.
I think there was a question from the phones.
John, this is Sue Stern, and so I had a quick question. But are you talking about the e-consult at UW Medicine?
Yeah, I'm going to talk about the virtual clinic here in a little bit, Sue.
Okay, then I'll just hold my comment.
Okay.
So Chris, I just have one more question. So for the providers, are there like appointment types for this, or is there any block on the provider's schedule to give them time to do these, or is it just something they're supposed to do in between?
Yeah, it varies a bit. So for example, in dermatology, we have a really good understanding of how long these take and what the demand is. So we do block out time for the dermatologist to do it. We have an expectation. We expect they take 6 or 7 minutes. So we expect about 8 an hour throughput. And you may look back and say you got it right or you got it wrong on a given day, but on average, hopefully you got it right. And similarly for other specialties, we have what we call desktop medicine. So we will block out a bit of time during the day, which we try to right size with the virtual volumes. So one nice thing with making it visible is you can look back and say, okay, you did this much virtual work in a year, and we believe it takes this much time, and therefore we can translate that much time into schedules. And, you do it for the average, and there's good days and bad days. People still end up doing quite a bit of it at home.
This is Julie. Would it be possible to get a copy of this presentation?
Totally.
Yeah, Julie, we'll do that. And Chris, follow up on that. It looked like you had a publication associated with this, like a manuscript. Is there?
That may have been.
You had P values and everything. Okay.
Oh yeah, that was just our own.
Okay.
Yeah, we have our GHRI.
Okay.
Or now KPHRI, which does things like that for us. I don't think we've published anything to be honest, but I'll have to check.
Okay. Great. Well, good. I'm gonna.
This is Gwen O'Keefe. I could just jump in. There actually was a book chapter published about this a few years ago.
Sorry, Gwen, repeat that. I didn't catch it.
We did actually publish a book chapter about this.
There you go.
In, I think it was 2013 or 2014. I can't recall.
Gwen, would it be possible to get a PDF of that so we could share and maybe even post on our website?
Sure.
Great.
Sure.
Thank you.
No problem.
Thanks, Gwen.
Yep.
Good. Good. If it's okay with folks, I'm going to talk about experience at the University of Washington, what we've had with eConsult. So I think, like a lot of health systems, one of our biggest challenges has been access. And if you kind of go the traditional way of hiring doctors and building more space, you're always behind. You're always a couple years behind. And we know that patients really don't like waiting. And we know that when they wait a long time, there's a high no-show rate. So these are challenges that we're really struggling with, and we were particularly interested in looking at eConsult. We were fortunate in that there was a Center for Medicare and Medicaid Innovation grant that was granted to AAMC and UCSF, and so they were working with academic partners around the country, and we were able to get on that second wave. But the other institutions that have been part of this are UC San Diego, University of Michigan, Ohio State, UNC, University of Virginia, so some very top tier institutions, and we've been really able to learn from their experience. But just kind of backtrack a little bit. What typically happens with a normal referral is that the PCP sees a patient and they would send the referral in through scheduling, and that can take weeks to months before they actually see that person in the office. So we give PCPs the option to send a person for e-consult. So when they type in Epic, referral endocrine, there are two options, either in person or through e-consult, and that's a discussion that occurs with the patient. So it's always up to the patient whether they want to be seen in person or have this e-consult. And our standard is maybe not as rigorous as Kaiser Group Health. We have a 3 business day turnaround, and our average is around 1 day for that. Another part of the process is what we call smart referrals. And it's basically making sure we have all the information that we need for those in-person referrals. It's the standard labs and things like that for our most common referrals. So it's smart referrals and e-consults is this whole project. But I'm going to talk about e-consults primarily. So Chris showed you what it looks like in his system. We are Epic-based as well. And you can see, you type in e-consult and you can see all the different specialties that are available in your system. And then once you click on your specialty, you type in what your referral is for, and a lot of that data gets slaved in. So for example, this is a case from endocrinology, a case of hypercalcemia, and there's an opportunity to ask the question. So the question is, please let me know the next steps for working up her hypercalcemia. What I haven't copied in there because there's so much is all the relevant labs, radiology, imaging, pathology, if that's relevant. It just automatically gets slaved in from Epic. And then you can see what's written back from the specialist. It's 3 to 4 paragraphs of what they think the most likely diagnosis is, and then the steps in workup and when it's appropriate for this person to maybe be seen in person. We also have the option, if the specialist does a referral, review of the case and everything, they say this is just too complex, then they can convert it to an in-person visit. And we don't, in that case, we don't charge. We're not saying that's a billable visit because it's not avoiding any kind of visit. But there's quite a bit of teaching that's involved in this. We often will go through the differential diagnosis so that the next time this doctor sees the case, maybe they don't have to send an e-consult in. This is an example from our e-consult for dermatology. And in this, there's not just the clinical description, but we have high quality photographs that are taken and are securely uploaded into Epic. So you can see what our dermatologist saw. They described the lesion. And in this case, it was a malignancy, a squamous cell carcinoma, and a punch biopsy was done and did indeed confirm that diagnosis. This is a good example of how within a couple of days, we had a diagnosis and the person got Mohs surgery within a week of this e-consult. So really short-circuited our normal process that may have been weeks to months to get in to see the dermatologist. And then from hematology, this is an example of someone who has monoclonal gammopathy of undetermined significance, or MGUS. So it's kind of a lab finding, and sent to our hematology clinic, and they just basically want to know, do I need to do more workup? Pretty exhaustive note that's written back, and kind of if-then guidance on when this person should get a bone marrow biopsy, and then if needed, be seen by person by the hematologist. Yeah.
In the specialty arena, obviously there's a lot of rote directive content. I assume that there's maybe some smart or dot phrases that you can blow in.
Yep.
So that you're not.
Definitely.
There's that capability.
Yeah, they do have that capability as well. They can customize it. Yeah. So I just wanted to give some real life examples of what we've had come through our e-consult thing. We've been doing this since July of 2016. So we went live with 3 specialties, and these are specialties that our colleagues around the country have said were particularly useful through e-consult, and we also had some access issues. This is all internal to UW Medicine, so this is with our neighborhood clinics and then our primary care clinics at both Harborview and at Roosevelt Clinic. So just to give you an example of what our top e-consults are for those three specialties, for dermatology, it's seborrheic keratosis, rash, neoplasm. We specifically had asked for no pigmented lesions because those have a high chance of being a melanoma, but we are picking up some of these basal cell and squamous cell carcinomas, which sometimes can be quite aggressive. For endocrinology, thyroid nodule, osteoporosis, and then hyper and hypothyroidism. And hematology, it's anemia, MFS, and thrombocytopenia. Those are kind of our most common cases. So to give you an idea how many cases we're getting, how many are answered, and how many get converted to an in-person, what you can see is the minority of those are getting converted, somewhere around 20%, so pretty typical what you were seeing, Chris. You can say 25% for dermatology. It's starting to grow and become more useful. So we asked the PCPs, if you didn't have this option, what would you have done? The vast majority, or 20, said they would have just ordered a standard referral, with some of them going through the back door with, paging their specialists or, sending them an in-basket message. So we did do a survey of our PCPs. We had over 40 who have responded, and 100% of them have said they're very satisfied with this. But I think sometimes it's important to see what they're actually writing. One of them said, more e-consults, please. We'd love to be able to do this for other specialties. They're pleased with the rapid turnaround and very detailed recommendation and rationale. So this is something that the PCPs are feeling like they want to take on and just need a little bit of hand-holding through the process. And then we looked at the specialists. They said they're getting quite a bit of uptake, and it seems to be working well. And some of the questions are quite complicated, and it did take them some time to craft a kind of a thoughtful reply. So we, like group health, we're tracking the time. We actually track it down to the actual minute. So they need to, in their note back, they have to say, I spent 22 minutes on this. And then we group it into CPT codes. We're obviously not dropping a bill, but just for internal purposes. And you can see that the vast majority of them are, under 20 minutes, with hematology maybe taking a little bit longer. Dermatology, like Chris said, and that sweet spot of 5 to 10 minutes is where most of their time is being spent. And very few of these are even over 20 minutes, and maybe just a handful over 30 minutes. So I wanted to flesh out the access issue that at least that we've seen at UW Medicine. So since we started this, we looked at time to getting into those three clinics based on a 14-day and a 30-day time to new appointment. And we took a baseline of the several months before this and then looked at the first quarter of having it. And in every single specialty, there was a significant improvement in access. And I think most notably in hematology, we went from 37% getting appointed under 30 days, going up to 52%. And in dermatology, we went from 35% to almost 50%. That's just within our first quarter. We only had one dermatologist doing the reading up until 2017, and have now been able to bring on 2 more. So we expect that dermatology will really pick up there as well. So the key takeaways is this is an initiative. It's still in the pilot process and grant funded that has improved access for our patients. We think it can enhance our payer mix because, quite honestly, if you have insurance, you're not going to wait months to be seen. You're going to go where your next appointment is available. And also, it is a very good use of resources. We're not building new bricks and mortar clinics and needing to hire additional doctors. And the PCPs love it. I'll just tell you that we've had a lot of EMR-based interventions, and pretty much all of them the doctors hate. This is the one EMR intervention where they are loving it. So that's a big win for our institution. That's showing the power of the EMR. And so we're just hoping to expand this to other specialties. So the next ones to go on live are GI, hepatology, and pulmonary. So we're just in the middle of an epic big upgrade. So everything's kind of on hold until that goes through. Yeah, there's a question from Sheila or Julie?
I didn't have a question. I just make a comment.
Oh, yeah.
Just that I feel that, patients have come in to expect care at a certain pace. I don't think providers are exempt from that. We all also expect that. We just don't get it.
Yeah.
So to be able to go from, it takes me 3 months to find out what derm is going to say, to tell my patient to a day or two, that's just phenomenal. Excellent work, you guys.
So Jeff, I understood right, patients aren't getting charged for this at all?
No, they're not.
Internal billing?
No, it's all internal billing. It's grant funded. I think that we've talked to UCSF, and UCSF does have a couple insurance companies that are paying it for it, with stipulations though that if it gets converted to an in-person visit, they would not charge for it because that's double billing. I know Michigan does that as well. And they just basically were able to show the improvement in access and patient satisfaction were the major drivers for insurance companies wanting to take advantage of this.
I think the cool thing is looking at it over the continuum, which I don't know how easy it would be to track this, but provider development and the elevation in the efficiency and the effectiveness and the timeliness of care. Because if you're developing those primary care providers, all it will take is a couple of those e-consults, of the same nature where they're like, okay, I got this, so in a way it's probably going to start weeding out the garden variety derm, and the e-consults will slowly kind of funnel into the more high level complex. Does that make sense?
Yeah. And so doesn't, I neglected to mention, we've actually seen that in our teledermatology because it's been up for several years. And we are getting feedback from providers that are saying more or less what you said, that I don't send this consult anymore because I've sent 10 of them and I got the same answer 10 times and now I'm not going to do it anymore. I know what to do.
And so I assume it means that the people who end up in the clinic, in the dermatologist clinic, that the complex items aren't even hitting e-consult, that those are the people that are going to end up, self-selecting to the clinic visits.
It's improving access overall, not just the in-person access, but even the e-consult access.
Right.
So over the longer term. As
there is a feedback learning loop that's implicit.
Huge investment.
Yeah.
Cool.
What my colleagues have said is that they really want to make sure that everyone who's being seen in clinic truly needs to be there.
Right.
These are the super complex or having them in person is a good value for everyone.
It'd also be cool to build a compendium. If you consider the volumes of information that's hitting those e-consults, if someone could go back and review and filter, what are the common questions that are hitting here, and where you almost have like an atlas or some sort of encyclopedia of like, these are the common things that are hitting. If your question is this, take a look at this. Because maybe the e-consult doesn't even need to happen.
That may be good for
there's
fellowships
amazing
and residency programs.
transfer of information.
Joelle, one of the things that we do is that our specialists actually go out and are meeting with these individual PCP clinics, and they're doing kind of a rolling education. So they'll review some of the e-consults and they'll say, this is an example of a good question. This is maybe something that was not so well worded, and they really do go through it and they say, well, in dermatology, these are top 3, and these kind of questions keep on coming up. So I'm going to give you a 5 or 10 minute overview of how do you manage an SK, right? So there is that feedback loop of education and in-person education.
Good. I think you're talking about an interesting idea that could be a higher level, like a smart referral in Epic. Like I could envision, like in neurology, headache is the #1 virtual consult. And so, you can have almost a referral to dermatology form where headache is a clinical complaint. When you click that, something else comes up saying, oh, here's our standard headache guidelines, recommendations. Have you already tried these things? Something like that. That just naturally pops up at the timing when you want it.
If this, do that.
Yeah.
Yeah. It's really cool.
Yeah. So, and John, it sounds like your e-consults are provider to provider at the moment. And
that's right.
The initial doc conveys that to the patient.
Yeah, the PCP is responsible for conveying that, and we're also at the step of making this all open as well. I think sometimes there are some sensitive things like maybe a cancer diagnosis, and that's why we've been a little bit slow in making this fully visible. So.
Yeah, with a good open note, that's when it gets tricky.
Yeah, I think what we're hoping to do is we have like a 7-day lag time, so it does give time for the PCP to have that phone call, and then it would go live.
So we haven't done it yet, but I'll just share what we think is going to work is we're creating these so that the closing provider is actually the initiating provider. So the encounter is kind of started, right, as an e-consult, and the specialist gives advice, sends it back to the originating doc. They review that, and then when they close it, that's when the patient can see it as an open note. Because we think that's the best point to close the loop. So it kind of goes back to the originating doc to make sure that you talk to the patient and they know what's going on and you're comfortable that you can close it and now it's on the chart. But that's not the way Epic naturally wants to do it, so it takes tweaking.
Well, I'd be interested to hear comments maybe from the insurance companies and Melina about any concerns about this, or
No, I think, or at least I know we had our government contracts team reaching out to the healthcare authority to find out kind of where they were in the process. And I think, I don't know if that inquiry sparked some energy, but I don't think we have any affirmative on that. But I think we see a value. I know when we were working down in Southwest Washington, we talked with a few providers, kind of what are the most emergent needs. And I mean, I think the most emergent needs, it seemed like they really needed the physician, and I mean, and this was on the psychiatry side, but we really thought that on the physician to physician on the, and trying to expand that to other specialties. I mean, I think we see it like much bigger. Obviously, Dr. Goff sees the whole picture, but, and in talking with them, I think it's like something that a lot of education and growth and getting them some, hearing this and seeing and getting some of the smaller practice, some of the smaller primary cares that aren't associated with larger systems need to see this because I think it's so valuable. I think it's.
You mentioned that in UCFS and San Francisco, that some of the insurers are reimbursing for this.
Yeah.
So I'd be interested to maybe see which insurers and how they're reimbursing.
Yeah, so the first one was that I guess UCSF is self-insured. So they just offered it to people who work for the
like
institution.
A self-employed kind of
thing. And then they went to, I think it was Likewise, I want to say, and they were able to show their internal data and cost savings with that.
So they're just reimbursing as a consult, or how?
They do it through the 9944 codes, the ones that we showed. So if it's less than 5 minutes, there's no charge. If it's 5 to 10, they have RVUs that are associated with that, and those RVUs then get converted through contracting to a dollar amount. So I think the lowest is maybe like $20 or $30, and a 30-minute is, I want to say, somewhere around $150. So that's what they're doing. And the other thing I would point out is that there's no facility fee with this. And that, at least in my institution, is a huge charge. So that can save patients a lot of money and save not just time, but money.
So what is the trend on the non-Medicaid side, like with the commercial plans, or as far as, because there seems to be a lot of interest in.
Well, there's no trend at this point.
Right.
Yeah, but I did run the 3 use case scenarios that you sent last time through our clinical team, and they confirmed that all 3 cases, at least the way they were written, especially under the caveat that they were replacement visits, all fell under the definition of storm forward. But as far as reimbursement for it right now, our policy does not cover that. And so I'm having conversations with the team as to how we can be more clear on what that is, especially as storm forward is something that's going to be a lot more common in the very near term. So we do need to address it, but of the 2-step process, step 1 is we need to confirm that the definition falls under storm forward. We just have to figure out how to explain what to do with that.
Okay. Cheryl Fuchala, I don't know if you're on the phone from Primera or anyone from Primera. Do you want to comment on this? not sure we have her.
Did you share the same? Case?
Say that again.
Did Cheryl get those same 3 cases to see if
Yes.
what her? Okay.
I have a question. These presentations obviously is for internal e-consult, right? Your system. Have we come across to external e-consult?
So that's what Mia talked about last time in LA County, and you basically need to set up a portal that can make those two EMRs talk to each other, and that software exists. You can actually buy it now to have a true statewide system, Ricardo. And I'm already getting requests from FQHCs to do this because they're seeing the value.
But there's no system here instead of Washington that we can, okay.
No,
That's
not
what
really. And I think in the e-consult there is a little, it's not the Epic e-consult, it's
Yeah,
an e-consult concept, but it's not the Epic.
Yeah, it's a custom built.
What I derive from this is that it works. I mean, the potential is there, and definitely access is an improvement from the current situation. So we do have the format, and it looks like reimbursement. It's something that is workable. It just makes a lot of sense, and the technology seems to be there for me as presentation. So are there any movements to link this organization like CMAR with University of Washington and any other specialty groups?
I would, that's a good conversation, and probably we need to talk to HCA about maybe sponsoring this, or, because that's really going to be the organization that's going to benefit the most from it.
And it is not significant. I mean, for instance, CMAR alone, we have about 100,000 plus lives on Medicaid.
Right.
And then some other 100,000 lives to the state of Washington, because we have a significant access issues for our primary care setting. So that's hopefully we will come to talk about those models.
So it sounds like maybe there's a recommendation from the group to explore the technology side of this.
Yeah, exactly. Because it looks like, I mean, it works. The technology there, the model works. Reimbursement can be worked out. Everybody wins.
And just so you know, if you want a dollar amount of how much it would cost to buy the LA County technology, it's around $2 million, which is not that much. When you think about when you start talking about EMRs and IT, $2 million is just the first week of consulting. So, yeah.
When we're looking at costs, we should also be including the insurers, because overall you were commenting on the facility fee. We're reducing total healthcare costs by increasing the efficiency and the effectiveness of care. So we're looking at all the stakeholders that should be at that table talking about how to incur and absorb that cost. We should be looking at the insurers.
And Brody, can I come back to your comment about, it sounds like having a better definition of how e-consult fits into Storm Forward. It seems like maybe we need to have a little better guidelines on that, or.
Well, Storm Forward is a really vague description. In fact, it's a description by describing what it's not rather than what it is, generally speaking. So my comment was less about defining it further, but more that the 3 use cases you provided under that vague definition, that there's agreement from our clinical side that they do fall under that broad, vague definition. Now, what we do with that, or how do we explain what's billable, what's not, I mean, that's kind of a step that's beyond agreeing that it's part of Storm Forward.
Can you further define Storm Forward then, either in the bill itself or with the insurance plans, to say something along the lines of Storm Forward technology that is used for medical decision making, that there's evidence of medical decision making in this interaction, because I think that's where it's not just data going somewhere to go to the grocery store, right? It's specifically for the intent and the purpose that it has altered the medical decision making process to be safer or more in line with new standards that are coming up, or more customized to the patient.
Well, theoretically, there's a higher complexity of thought processes in that, right?
Right. Well, and I mean, you already use that terminology for coding and billing in our universe, medical decision making is its own category for your billing complexity. But I wonder if that would help us further define. It's not just a picture with no clinical history and no real good guidance that came back.
In my mind, I think the highest possible bar for store and forward is the connectivity to the entire EMR, right? So that's, I think, why one reason you can succeed at UW and we succeed at KP Washington is it's the same EMR. So every detail of the patient's history is essentially transmitted along with the consult. It's completely there. The other extreme, you're right, you could imagine like a dermatology virtual service where all you get's a photo, and that's it. That would be, I think, not meeting store and forward in my opinion. So I think there's somewhere between those two, and one could craft, I guess, criteria, sort of thinking about a standard consult, like minimal criteria that has to include, allergies, past history, past surgery, all the things that we normally want from a granddaddy visit probably should be there in the store and forward. And the whole standard would be the entire EMR is connected, either through Care Anywhere or internally.
What I like that e-consult also that perhaps makes it more efficient was implicitly what you were saying is that you're requiring the PCP to get smarter than what we are right now. That's a big issue. And that's why sometimes dermatologists and very scant information, they want to see the patient anyways. This is forcing you to put your 2 cents of what you're thinking. And I think that's probably making it more effective in that sense. Even if you don't see the patient, you have all the information. But again, comes back to do you have all the information, the specialist? Do you have all the information that you require? Internally, obviously, but for external, I can see there's going to be some challenges, John, because unless we share the same EHR, would be the transmittal information won't be as efficient.
Well, it sounds like there's interest in this, and I'm just I want to brainstorm what would be the next logical steps to explore this. Do you think maybe getting something back from HCA, that be the next
and then
step?
and then trying to dialogue with them about it.
If HCA came up with a policy, would that be something that you think Primera and Regents would also support? Or would you want to have a separate process, Cody?
Well, without knowing what that policy would be, and also people having to look at it, but definitely more definition on what it is. Like I like that definition. I mean, just from a practical speaking, it makes a lot of sense to me that it's replacing the visit, but system-wide, it's really hard for us to, review that piece of it. So is it? I'm just thinking out loud here, but is it that there's no visit with the same doctor within a certain period of time? Is it the same system? Is it in the same specialty? Like there's all these things that we need to look at from a systems perspective to determine whether something actually was a replacement for it or not. But the premise of it, I think, is that's the goal, right? And you even said it for yourself that if you knew it wasn't a replacement, you wouldn't bill it as a service. And so I think we're all conceptually on the same page. Is how do you operationalize something that's really hard to measure and track? So.
Well, we have a different product it's more direct to consumer, so it's not really e-consult, but we do the same thing where, that's not really fair to bill them for a visit that we say, not enough information, go see a in-person visit, and then that's not a billable event. I think this group could probably come up with year 2 experiences and some other input to figure out. It sounds like you arbitrarily chose within, what did you say, 4 weeks or something?
8 weeks was for our internal value.
Maybe that's too long, maybe it's not long enough, but I think we could probably help come up with something that could be
criteria
acceptable in the wider community.
Well, can I propose that maybe Chris and I put something pen to paper, and next time we'll kind of come back with, this is something that we would like to move towards reimbursement, and that would make sense. And I don't know if there's a pilot period where we look at cost savings and things like that, but
and so to check on that, I think there's 2 big buckets. One is how much clinical information is part of the store and forward. So again, is it the whole EMR? Is it a photo? How much is needed to meet that bar? And then on the back end, how do you know it was a legitimate, lack of a better word, valuable replacement for a face-to-face visit? I think those are probably the 2
key variables
areas we can talk about a lot.
Right. I think looking at standards of care and also what components are critical for billing, and then looking for alignment between the two.
Right.
Would make sense.
Something to measure the outcome. So like, like let's say the healthcare authority, if they did a pilot or something, or willing to support it, they probably want to see some kind of results and how that, how that transformed or how it, did something, and then expand it to a broader,
I'm
the broader, most complete population.
I'm familiar with something that was done along those lines in Mississippi for diabetes. It was a limited pilot.
So if we could introduce it as a pilot, it seems like there's better ability to get some adoption from.
You probably have to define some metrics to measure the
Right.
success.
Right, so that they know that there's building standards along the way, that there's, the other thing I was thinking of is in the CPT codes, there's a component. I know you said there's not a facility fee, but there's the there's the location or the adjuster for being an office visit. That's part of the overhead and the reimbursement. And so, I could see, these visits may pay slightly less than that, just because, I could see the element taking that down and dicing it down to, but I didn't know if that was something that you thought about, or how to include why you still need to have that, to include that there's somebody in the office, you're still having to, somebody's still, the member's not there, but there is still a facility component. There's operating and overhead expenses related to the operation of what you're doing. But I could just see that coming up as there's, there is a, origination fee sort of built into the CPT.
And to maintain the technology, you have different types of expenses.
Exactly,
than
it's
what
just
you
different,
have.
but the outcomes can be so much better. Again, the no-show rate for our population, there's all kinds of reasons for our population why this is.
And I think looking at a cost savings piece, it would be part of a pitch to get a
Right.
pilot of some sort running, and what you would look at. In this case, you have a great case with UW of, okay, no facility fee, there's a facility fee.
Right.
Because that wouldn't necessarily be part of your, not in all instances would a dermatologist have a facility fee. Do you know
Right,
what I mean?
exactly,
In the state. It's only
exactly.
in certain places that they might have that facility fee.
Right.
I think that sort of third bucket occurred to me that would be crucial for Store and Forward, and that's being clear about how you're confident the patient's involved. So video, obviously the patient's involved.
Right, are they getting a
Hopefully,
follow-up in
obviously,
your consult? Or
but
are they
Store
getting
and
a
Forward,
follow-up?
right, so at some point, if these are billable to an insurer, then they may be billable to the patient as well. And the last thing you would want is patients who didn't agree to a Store and Forward visit, or worst case, didn't even know it was happening.
Right.
So how do you build that in to the guarantee that patients consent, if you will, and agree and understand that it's happening?
And maybe that's just, they have to get a transcript of the interaction.
Right, that's what I was
at the
gonna say.
end.
That
In
could
order
be
to
as
be able
simple
to
as them
vote.
receiving
Yeah.
something
You
at
want
the end of the
upfront and
visit.
closing
Like they get
the
something in the mail, that that
Or
your
in their
physicians
email.
talked, exactly.
Like
I
an
think
after
both-
visit summary, or
Yep.
and probably clarity around who actually bills for that, and what does that end product look like. Maybe there's like a final document, like a office visit, that kind of puts everything together and demonstrates that someone took responsibility for integrating and, applying all the information that occurred with conclusion.
Ricardo.
I wanted to say that I'm looking at the telehealth, the full telehealth, telemedicine visit with the patient on the other side, PD and so forth, and the e-consult, both tiers are, I think there's a fluidity between the PCP of the way to the full referral with these two tiers. But I like the e-consult, the way you guys presented it. It has a lot of potential. Perhaps you're going to minimize or to appropriately use the telehealth model, because I suspect e-consult is going to be, if available, it's probably going to be the preferred way of communication.
Right.
And a lot of stuff can be resolved at that level. It has the potential, again, to making me a PCP smarter, but also learning along the way, because I'm involved, I'm communicating with you, and I need to sound smart. and learn along the way. As you said during one of the cases, next time I'm not going to send you the same page because I know you told me, you mentioned to me, and everybody wins. So I think that emphasis should be placed on both tiers. Again, there is fluidity. I don't think there's competition at all. There are patients who really deserve to go to health or a full-blown referral, but there are those patients who you can save him a visit from one city to the next, and going and waiting and all that. Doing all of that. That fluidity, I really like it. My point is, I like this body to think, putting emphasis on both tiers, the e-consult as well as the full-blown telehealth with a video.
I think that's
Well, maybe we can
in the
wrap this
rural
up.
areas too, like just in the locations, but like how rural areas can benefit from this in a huge way, both on the e-consult and the telehealth, but like the packaging it together, especially to the healthcare authority. There's huge access issues, and just not having that, maybe the expertise. A member shows up with some, and they need, it's like they should get, there should be reimbursement for that. Everybody would, I don't know, because the member would have to go over, it would save them a trip over to here if these two physicians could talk. It's a huge, just the efficiency and time in the member getting to the right, to the right care. It just seems like it could be pitched together. I like that whole.
Okay. Well, I just want to wrap this up because I know we have a couple of other agenda items. But before we do that, anyone on the phone or video who wanted to chime in? I know, Gwen, you had typed in something about Rubicon MD. Do you want to say a little bit about that? Do I still have you on the phone? If not, I'll just read what Gwen typed up. She said that there's actually a commercial plan that does e-consults. It's called Rubicon MD, and Gwen has some experience working with them in Q-Liance, which is the concierge kind of medicine, and at least in Q-Liance's experience, it's been very successful and well received by both patients and the PCPs. Any other comments from the phone? Okay. Well, it sounds like we got some homework to do.
Yeah.
We'll come back, and the idea here is this is like a rough draft of kind of almost like a guideline of this is how maybe e-consults should be done, and how maybe we could study this, and really, hey, this is going to save us money here in Washington State. We'll have to address some of the IT issues that you bring up. Okay. Well, good. So I think the next thing we're going to do is kind of change gears and turn it over to Sheila, who has very kindly agreed to take on this issue of fraud prevention. And just to kind of level set the conversation, I always like to hear what Senator Becker says, is how do we keep doctors out of trouble? So this is in that vein. We're going to look to Sheila to give us some advice on how do we keep our doctors from committing fraud.
Well, this isn't anything new, and so even though this is just a different way to deliver clinical care, the same fraud rules apply. I mean, there's the False Claims Act that's at the federal level. We have a False Claims Act here at the state level, and so I don't know if this is something that we just want to include as part of our toolkit, as part of what we're pulling together, but just to remind providers that the rules are the same. You're providing health care, you need to have the documentation to support the health care that you're providing. You have to demonstrate the medical necessity of the health care, and the documentation needs to be equivalent to the services that are being provided. So the one thing that I guess I think about more with the telehealth is, so fraud is there. You have the bell curve, right? You've got your 5% that will never do anything wrong. You've got your 5% that will always try to figure out how to get around the rules. But for the rest of the 90%, I think the providers should understand and know about fraud, because again, this isn't anything new as far as billing for services that you didn't provide. I think when I hear these conversations that we keep having about telehealth, though, the one thing that I think that we need some clarity on sooner than later is really understanding what the documentation requirements need to be for these services to be billable.
Yeah.
And the reason I'm bringing this up is, I mean, everybody knows all of you who are providers, you I'm sure had some kind of coding audit at one time or another within your professional life, and sometimes you agree with how the coders are interpreting your documentation. I think for this, though, that we need to get that requirement clarified soon, because there's a lot of providers who are already doing telehealth, right, that aren't billing for it. And so it's much harder to go back and relearn something new or to learn to do something differently than how you've been doing it. Because if we truly want to get to billable and reimbursable services, I think we need to make sure that we can provide the providers clear guidelines for what the documentation requirements are for e-consults, or how, for anything that we're going to be doing telehealth-wise. And so I think that's one of the things that I'm hoping that we can pull together and create those guidelines sooner than later. And so I'm kind of looking at our payers here to help us with that. You know, we all know what, you know, the other, you know, what we can bill right now for professional services. And so do we take that and start creating new guidelines from what already exists so that we can determine what is going to be reimbursable at what level and what the RVUs are going to be, because that's the driver behind this. Is providers want to be reimbursed for these services because they're providing clinical care, and just because it's different doesn't mean that it shouldn't be reimbursable. And so we need to determine that, I think, sooner than later.
I think from the provider lens, I absolutely agree with you. Yeah, absolutely, documentation has to exist. The fraud prevention wise has to be the same across the board. From a coding perspective, I almost think that it comes back to what we struggled with for a couple of meetings, is this 99444, and that at current state anyway, there's really only one level. And as a provider, what I'm, paying closer attention to exactly what's going in my note is because I know this was a 99214 and not a 99213. Whereas right now, if there's only one code, how would we be able to create a guideline to how much needs to be in that note? Because it could go anywhere from a 99211 required documentation to a 215. Now, from a malpractice lens and from a fraud prevention lens, different story. It just needs to be there, whatever it is you're doing. But from the billing perspective, it's going to be, I think that's where we're going to get hung up again if we don't also kind of circle back on that topic.
No, I agree. And I think that's one of the things that I think about when we talk about the telehealth, and I hear about so many providers like, John and Chris, you've been doing this for a really long time. So you're taking advantage of the technology and moving forward with providing good clinical care. But how do we make sure that the documentation is meeting whatever the requirement is going to be, so as we continue to roll this out to other providers that they have those guidelines?
Are you speaking just of e-consults right now and storing forward, or are you talking about all telehealth visits?
Probably those two to start off with. I think,
because right now, you may be familiar, but as providers, I bill my 99213, 99214. I just go about my business, and that's based on time and complexity of care, right? And then I use a GT modifier to identify it as a remote encounter. So I don't have to think about the variability in what I'm doing and how I should document based on what I did in the visit or didn't do. I just do my visit and I bill it, but then it's identified, it's flagged as a remote encounter. And then there's reimbursement that's attached to that, but that varies state by state and by insurer.
And I'm just not sure all providers know that. So I know that you're doing that. I'm not sure all other organizations that are doing a remote visit like that know to add the G modifier. Are you doing that, or?
No, because it depends on the payer in which, if they want the GT or if they want the 99444. I think it gets, from my understanding, it's getting clouded in the, well, you might be writing that, but somebody in the back end might be changing it to be, but this patient's insurance plan is this, and they want it in this other language, so I'm your coding specialist, and I'm going to change it to that so it can get paid something. But I think we're not necessarily seeing that whole part of the picture.
Which is not always right, by the way.
Correct. I agree with you. It's not always right.
So that's a whole nother
Sometimes they
institutional issue when coders are making judgments without conferring with you. But we need to standardize this as well.
But I think where I'm getting confused and lost myself is a coder would have to look at that, because I'm not going to memorize that Regions wants it this way, Medicare wants it that way. I'm not going to memorize 2 or 3 different ways to do it and then have to look at a person's insurance to find out how I'm going to bill their service. Because I also think the downstream effect is I'm going to look at their insurance and change the type of care I'm giving, which is not what any of us want. We want to create the same care no matter who their insurer is. That should be something later, not in the foreground of your thinking as you're trying to finish up your documentation.
Well, and typically, billers will put it through some type of scrubber by carrier to see how the carrier wants things coded, because it's, you know, that this isn't new just for telehealth. This exists for other services too.
Sheila, you had copied the document from CMS. I think it's just, we scattered them around here. And I think this is a resource that we post on our website, but it basically, it goes through what CMS guidance is on how to bill for telehealth, and has all the CPT codes that it reimburses for and the GT. And you know, what I've been told by our coders is that from almost every situation, we follow CMS guidance on how to code. So I guess my question to the group here is, why not just follow this document?
And you know, even in
federal guidelines.
the e-consult and the store and forward, those visits are originating with a face-to-face. There is a provider in there. You know, it's not sort of the mushy, the patient was never really seen. Which could be argued that it could be substantiated in a regular billing code.
Yeah, I mean, basically, what you said, Joelle, about billing by time and then at GT, that's essentially what CMS tells you to do.
And HCA will follow Medicare. I mean, it's usually, I mean, if they don't reimburse everything that Medicare does, but they usually follow suit for it. So it's nice, there's a standard.
This Cara, and I just wanted to add in, we've been advised by the University of Washington physicians billing folks that in addition to adding the GT modifier and then doing the Q3014 code on the patient side, that we should have sort of a standardized phrase that states that this was done by telemedicine, and you know, for every visit that's done by telemedicine that has a GT, it also should have the phrase that, and I can share the one that we can connect with you if you like. But I'm wondering, Joelle, if you're doing that as well. Have you guys standardized something like that?
Oh yeah, we have a statement that says this visit was can you hear me okay? Was conducted by video audio conferencing in an encrypted setting. So we have it as just a dot phrase, dot tele, that drives it in, but the provider's responsible for making sure it's there.
Yeah, I think Denny had shared that, and it was in the context of kind of consent as well.
And that's not what we use. It's more straightforward. I mean, it's
that's pretty standard. Whenever I go to any kind of telemedicine conference, when they ask about billing, that you always have to have that phrase. This visit was conducted via live face-to-face video teleconference, and you can throw in the security bit if you want to. But it's pretty standard guidance, I've heard.
Would it show e-consult versus telehealth? I mean, would it show like?
So what we do is our e-consults are the
You
notes
say e-consult,
are
yeah,
labeled
clear.
differently, and similar for any kind of telemedicine visit. It would say telemedicine cardiology, outpatient cardiology, so that you can just see from the very first line, the title of the document. It's a totally different document.
But in the coding to healthcare authority or whatever, it's how to code it so that they could see that too. So if it was just GT modifier, what would distinguish e-consult from telehealth?
It's a GX. You use a different
you do.
modifier.
Okay,
It's a
yes,
GX
thank
modifier.
you. Thank you.
Or it's a live face-to-face.
So that's
GT.
perfect. That's all, yeah.
Is it listed here, John?
Yeah, I'm not sure. It's actually in the text, I think.
One of the back pages.
Okay, all right.
You're looking for the GT and the.
Oh, sorry, GQ. That was GQ. Yeah.
GQ?
Not GQ. GQ, sorry.
Is there a parallel
It's
document for
P6.
e-consults? So this is care for
It's all laid
asynchronous
out. We
and
got
for
the
synchronous,
codes,
but
Yeah, this is
always
the
with the
one
patient
we-
involved, but there's no parallel document for
I
what
have
codes they
not
use
seen
for.
anything for Store and Forward. I mean, partly because Store and Forward and Medicare is only paid in Alaska and Hawaii.
Yeah.
So I can dig it up and see if there is anything out there. But
Well, just, I guess not to go backwards in the agenda, but the 99446 through the 449, what was the premise of, is that what you guys use as well for your e-consults?
Internally, that's what we're going to use when we go live, but yes,
Just to track them.
to track them.
Seems like a lot of the telehealth companies, that's how their systems are set up to do it too. They use those codes.
The lower end codes, the 441s through the 444s. So I just want to understand the root, because you were directing questions. So this was first framed as a documentation question, but it sounds like it's more of a billing code question at the root, because, well, I'm not a clinician, so I'm going to make a comment that you could all correct me on, but my assumption is that the documentation required for a virtual visit, like, I wouldn't expect anything more than what is needed for an in-person visit. So it sounds like your comments are more that you don't necessarily agree with the codes that should be built, less so about what documentation is necessary to justify reimbursement.
I think what I was trying to ask was, it's very clear to me as a provider how much, exactly what type of documentation I need, and how much in each section for each of the outpatient office visit type codes. But if telemedicine only has one code, then I don't know what degree of complexity I need to have documented to cover my bases from a coding perspective. Now, we could assign that and say, okay, if it's 99444 that everybody's using for all telemedicine, this is how much documentation you need. It's the same language as what a 99213 is, or whatever, pick one. But I think where my question comes in is, all the billing and coding is all set up in a way that there is a huge spectrum over the degree of documentation that's needed. In this case, it's sounding like we've really chosen, well, CMS is doing it differently. There's really one code that's going to get reimbursed, so it doesn't express to the clinician which level of that complexity do I need to have documented. So from a fraud prevention, absolutely, I mean, you need to have documented whatever it was you did, but am I going to go into detail on their family history on if I don't need it and it didn't end up being relevant anyway? I'm probably not going to put it in there. I probably talked about it or knew something about it, but I don't have to take the time to write it in there because it's not relevant for this particular bill visit. So that's what I'm trying to get clarity on, is how would it be interpreted? How could we come up with a guideline if we don't have where in the spectrum does this 99444 fall?
And the reason I brought it up in kind of the context of fraud is it's not really fraud, but sometimes what ends up happening is when, we have payer audits that come in and take a look at our chart notes, and, the documentation doesn't support the level of service bill. So how do we make sure that we give guidelines to the providers about what the minimum documentation needs to be reimbursed at whatever level that ends up being?
So are you saying that if policies were changed to the 211, the 213, that the documentation question would be answered?
It would be answered, yeah, because what this is showing is there's a whole host of codes which come with them, a whole host of requirements to meet the level of that code that everybody's already familiar with. And then you just tag on the modifier that says, but it was conducted by telemedicine or telehealth.
The easiest way from the provider's perspective, because it's already complex enough.
Yeah.
It is already complex enough, yes.
Don't need to add another level of complexity.
Is there anyone at this table using the 9944 series?
not out of the e-consult, no.
We use it, but it's not our providers.
For face-to-face?
Actually, Emily is our Epic version of it. Are they using the 99444?
We're
Emily,
using
you-
that same scrubbing method where on the back end, finance is converting it into a 99444 for Premier and Region.
So it'd be exactly what you're doing.
Yeah,
You
but
know,
it's
documenting
those
my
codes.
99213, but then somebody changes it in the background. My concern with that comes, but what if it was a 99, I'd be exaggerating here. What if it really was a 99215 that you documented to the level of that, thinking, I'm gonna spend extra time on this to cover my base on everything, and you send it off and it still gets turned into the 99444 and you just don't know it. So you just spent a lot of extra time for really no benefit.
I'd be curious to see if like the healthcare authority would get down to, you know, the simplified code for those services, or they would want to stay with the more description or the wider range of codes. I don't know.
I think the healthcare authority is gonna follow a federal guidance because they're a federal
That's right, yeah.
program. They would, it'd be
That's
very
how I
highly
feel.
unusual
That's
for
what I
them to
would,
deviate.
right.
Well, I think our discussion is kind of veering off again into coding. It's almost like a magnetic pole. So maybe we can come back to fraud and Sheila, it sounds like, you know, if we had a guy here who is just trying to get into telemedicine, we'd say definitely make sure that you're documenting properly, and you need to have that code, that phrase. That's a key thing. The same rules apply as in person as they work for telemedicine. Any other kind of fraud things that we should be aware of?
No, I just wrote some notes just to make sure. So I mean, it's just like for anything else that you document and you bill for. You know, you have to have the services need to be documented. They must be medically necessary. Documentation needs to support the level of services billed, and they need to be signed, dated, and time. So it's just
requesting providers, I think, is often
right,
yeah.
right. And then I think also too having that extra phrase on the notes, whether it's an e-consult or a virtual visit, so it's very easy, so that if you get audited, when their auditor is looking at the chart note, they know exactly what type of visit it was, whether you know it was a virtual visit or not. So I mean, I just think some bullet points just as some guidelines, because like what we find sometimes, and I kind of go back to the patient portal when we implemented the patient portal a long time ago, people kind of forget that some of the same rules apply even though it's a new functionality. You're still releasing records to patients. You still need to make sure that when they sign up for the portal that you know that they're the right person. So again, it's just trying to remind people that even though the technology may be new and the way that the clinical services are being delivered is new, that some of the same rules apply when you're billing for those services and being reimbursed either by CMS or by a payer.
Okay. Great. Any other questions about fraud and fraud prevention?
John,
yes, Sue.
sorry, I just want to go back to at some point when we go back to documentation, again, we should consider when it's more relevant, it's not relevant now, but other types of telemedicine or other venues for telemedicine and documentation related to that.
Okay. And are there specific examples you're thinking of, Sue? Just so we can tee it up.
If we develop more emergency telehealth or telemedicine in the state, I think then more ICU telehealth, things like that. And that's what I was thinking.
Okay.
And I mean, that's already relevant for some of the stroke stuff, right?
Definitely.
That is emergency telehealth.
Okay, thanks. Was there someone else who wanted to add a comment? Okay. Well, great. I think what we wanted to do then is talk for the last 20 minutes about some of our FAQs. So these are two documents. One is going to be for patients and one's for providers. And we went over those last time. I'm going to share my screen because I did a little bit of editing of that, and I wanted to. I think the versions that you guys have do not reflect some of my edits. The first most obvious thing is the formatting. I converted the fonts, and I kind of like this format where you have the question in bold and underlined rather than the Q and with an A. And I have harmonized what is telemedicine between the patient document and this is for providers. I kind of like what the ATA have written as a little bit more understandable and less academic, I guess, put it that way.
Just a quick correction, John, on questions is misspelled at the top.
Oh, thank you. All right. So for those folks who may not be able to see our screen and are following along with, from printed versions, what is telemedicine? Telemedicine is the remote delivery of healthcare services and clinical information using telecommunications technology. This includes a wide array of clinical services using internet, wireless, satellite, and telephone media. So pretty short and sweet. And this is the document for providers. What is this distinction between telemedicine and telehealth? And Sheila, I kind of made a little bit of changes to what ATA had written. And I said that strictly speaking, telemedicine is focused on clinical aspects of care, whereas telehealth is a broader term that encompasses clinical care plus health-related education, public health, and health administration. And then I just pretty much kept what you had there. So,
Well, and I made a few modifications from
okay.
what the ATA had published as well, so.
Okay. And then how typical is telemedicine? And I didn't change anything here, Sheila. Is it safe? This is straight from the ATA. Well, what is the relationship of telemedicine and HIT? No changes here. And then where can patients get access to telemedicine services? And they can ask their doctor, hospital, healthcare provider, and then I think most of the changes are going to be in payment. I'll keep on coming back to that.
Codes and payment.
Codes and payment, yeah. And this is where I got a little bit more specific to be Washington State. I think the ATA had, they were trying to cover all 50 states. And I basically just copied from our Senate Bill 5175 here. You'll notice that's on the screen is this sentence saying that ATA is pushing the Centers for Medicare and Medicaid in Congress to remove those. I didn't really feel like that was necessary. I mean, I felt like that felt like speculation and lobbying and things like that. And I would say maybe we need to cut that out. And then this is maybe where I'll look at Brody to see if our response is okay. Do private insurance plans usually cover telemedicine services? I just said yes, the same restrictions apply as for Medicaid. To find out if your insurance company covers telehealth services, please contact your benefits manager. And it's pretty general, and allows for changes and flexibility there. But are you okay with that?
Yeah, we'll review
Okay.
all of these things. Just my only comment about this is my understanding of the term benefits manager applies to people who have employer-based insurance. So, I mean, if you're an individual, you don't technically have a benefits manager.
Okay.
Probably not. So
Who, maybe just, or would you, or contact the insurance company directly?
yeah, we'll take a look at this and just make it more applicable to recognizing that everyone doesn't get coverage through their employer.
Right. And then we just say there's more to learn from ATA.
Oh, his has a different version.
Yeah, sorry.
And then, John, I don't know if you saw my update that I had sent out, because as a follow-up from the last meeting, I think, Julie, you had suggested to pull out the Washington State one, which I did, and I added that on.
Yeah.
I don't know if that's necessarily helpful to people or not. I don't have a copy with me, but I emailed that yesterday. I think after Priscilla sent it out, and I saw that it didn't have my updated one.
Oh, I'm sorry.
So the updated
Yeah,
one.
we're working on 3
actually
different
had
versions. Okay.
Yes, that's it.
Oh, it's right here. Is this it? This is from the ATA. Do you want to include this, Sheila?
Well, it was a recommendation of, when we talked about the last time, I had the link if you wanted to have more information specific about your state.
Yeah.
And I think someone suggested, well, maybe we could just add the one for Washington so people didn't have to click on the link.
Okay.
I left the link in there in case they wanted to look at a different state. Yeah. So I put that on there, and I don't know if people think that that's helpful or not for, for patients.
What do you think, having this?
Or is there
It's almost a
way you
scorecard,
could-
though.
Right.
Yeah,
I wonder if you can just cut and paste the piece from it that would be relevant in this FAQ rather than the whole page.
Yeah, I'm not really sure. When I read it, I'm not sure how helpful I thought it was, but that's just me personally. So I don't know what others think.
It's great as a policy document.
Yeah.
But as, I mean, patients reading this, like, I mean, do we want to have a Washington State gets an F for telerehabilitation?
Yeah.
I don't know. I mean, some of these grades are pretty arbitrary too, right?
Well, and to understand the score, you really need to read the whole report. So, I'm not, anyway.
I think
there
the
it
link,
is.
the link should be enough.
Thank you for.
The link is enough.
The link is enough. Anybody that is more curious.
Yeah, so when I look at it, it's like,
I
well,
was
I'm
just gonna make
not
a
sure
comment.
that's helpful.
Yeah.
Because the intent from my perspective for the questionnaire for the patient is to be kind of high level, just to give them some kind of general information. And if they want to dive into it, they can read the, 150-page report from the American Telemedicine Association. But that's also broader. That's not just necessarily state specific. And that would require probably updates to that as things may change in Washington State. So we have to kind of keep looking at that. So anyway, there it is in case people are interested in it, but I'm not sure if it's really helpful.
I think Carl wanted to say something.
Yeah, I was just going to say that it's almost a little bit misleading because it refers to the Washington parity law, and I don't think we actually do have. I don't think it's a parity that we have, and so maybe we need to correct ETA on that as well.
Yeah, I think it sounds like a lot of people are maybe saying we just keep the link and delete this scorecard here.
I would agree.
Okay.
At least people know what's on.
All right. Well, so this is for patients. I think it gets in at 2 pages, which is what we were aiming for. Kind of hits the highlights. I'll send this around one more time, incorporating some of your changes that are Washington State specific. Maybe we can look at this one here.
I'm not sure how to ask the question, but I was asked by some people at our company for what the purpose was of this document, because depending on what the purpose is, different sets of people would look at it, and I'm referring to lawyers, for example. So they're asking, is this a guideline, is this a recommendation, is this an endorsement? Is this just, general information?
It's general information.
So I'm not sure, to make our lawyers feel a little bit more comfortable, I'm not sure what we would need to do to it to make it clear as such, but I'm just asking.
No, this is not a guideline, it's just general information.
That you could find anywhere.
Right.
If you just
It's a
Google.
re-summary of things that already exist.
Well, and when I started looking at the Q&As for telehealth, there's so many out there, and it seemed like the American Telemedicine Association had kind of the clearest one. So they're all very similar. And the other piece too is I did email them to see if we could use this, if we need to put a copyright on there or something. So I think by the time we're done with it, we'll have some reference on there that either we've received copyright, or maybe a lot of times when I find out from organizations like this, they just want to be acknowledged that that their content was used in developing this Q&A. So hopefully that will help, because we'll have some acknowledgement, something referencing back to the ATA.
So we have a similar document that actually goes out in the mail to our patients who are scheduled for a telehealth visit for the first time. And it's very similar to this. Just basic informational.
And we do too. It's a little bit more practical, like what to expect. And
for providers, that might be nice to have something like that, so they don't have to create their own, where they could download it.
I think that
Standard
was
tools
the
for
intent of
them,
having one for patients and one for providers.
I think we should, that's the idea. This is the one for providers, right?
Yeah. This is the one that it says, I think the third question is, can clinicians get paid for telemedicine? And it gets
Working on it.
Right.
Yeah, and so I say yes, although there are certain restrictions based on the type of insurance being billed. And I just basically say the restrictions are guided by language, and it's in about 5175. My question is, should we add a link to that legislation so that people are interested?
I think a link would be useful.
Okay. Right. And then I, just basically verbatim typed out what was in the bill here. Calling out that in 2017, originating sites are relevant. We'll change in 2018. And then we look at Medicare. So the rural requirement is the one that I think trips a lot of people up.
Is there maybe a table format that we could use for
determining
the one that we have A through E? Here's all the ways it can kind of qualify. Is there an easier way to make it more reader friendly? I'm a primary care doc in such and such setting, FQHC or something, and I just want to at a glance know, do I even bother keep reading this document?
Put checkbox, I don't know.
Yeah, I don't know, like a graphic that has checkboxes of, what's an originating site, and then and then the years, 2017, yes, this qualifies, 2018, now you do qualify, and home office would be one I would put on there. It's not on the list, but I would put, can I do this from my home office? Well, it would be red, I guess.
Okay. Maybe converting this to more of a checklisty kind of appearance here on this. Okay.
Trying to figure out how could we express it easier.
Another issue, last time that I read this one, it was a little bit confusing, and that is on the question, do I need a special consent? And the answer is no, but everything else means telling me, yes, you have to. And this is an example. I don't know if I'm misreading it or what.
Well, so that's not a consent document per se, Ricardo. What it is it's documenting that you had the conversation.
Yeah, and I read that, so I can start my note saying, this is a blah, 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 this exam was initially, and then it changes. What I'm writing says, do you understand the risk and benefits? And am I supposed to say, do you understand yes or no? This seems like a consent actually for the patient. But anyways, it might be that way I'm reading it. But you said that this is what it should be in the note?
I think this was just meant to be as an example if somebody was starting from square one, that you could use this if you wanted. I don't think we were trying to be prescriptive of it has to have each one of these little elements in it.
I also thought it was a little confusing, and as I try to remember back to our conversation around it, I guess the way I think is the question saying, is it legally required to use a special consent form? And I think we felt the answer to that was no.
That's what Adam told us.
But then we thought as a best practice, you may want to, and here's an example. So maybe the wording could be cleared up.
And these are multiple examples. So the it says the following is an example of what could be included. So the first statement is actually the statement that I provided that we use. That's our dot phrase. The second is what Denny uses, I think, at his location. So, I mean, we could say, the following could be utilized within your documentation, or, but this exam was initially conducted is the statement at the end of our clinical note that identifies it as a telehealth visit.
And that's the only
So it'll be at
special
the
part.
end.
That's it.
It's just that
Yeah.
one line.
Something
so these
like-
are two separate examples.
Yeah, I think they're with different utility.
Documenting a procedure, for instance, even a toenail removal, after properly consent and the patient chose to, something like that. Like after proper consent and inform and the patient understanding, blah, 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 the risk, the patient chose to receive care. And then at the end, say this visit was done under telemedicine or whatever.
You might also want
Just
to,
give you what you wrote. Well, I can put it in there.
I'll send this.
this stuff from Denny could be a PDF document that they can link to that says, this is, this is the dot phrase that can be, that something similar should be used within your clinical note to identify it and verify that this was conducted by audio video conferencing. But then this other business, you have chosen all the way down through eye doctor such and such. Well, I mean, that's another smart phrase or a dot phrase, right? But basically that could be in a PDF that says, this is an example of a consent that you could use in your office. Because essentially, someone theoretically would be signing this, right? And you'd be scanning it in.
Could we go back to just rewording the Q&A a little bit, to Chris's point, and then say the most simple form of best practice is, and then just have the one-liner version. If you would like to see other forms of consent that are more comprehensive, click here or go to this PDF or whatever. Because then it's taking, you should at least have this.
And although
And your
consents are
general
not
medical
required, if you're so inclined, you can use this. Or this is an example of what's utilized in the community.
Do you want to, if you guys can send me your comments on this, how to phrase it, yeah. That'd be great.
It might be a place to the or homework part to lay the framework that it may turn out some payers are going to want to see documentation that the patient agreed to the visit, so it may become a reimbursement issue to document this.
But Adam was talking about that. Adam wasn't he saying by signing, at least in the traditional encounter setting, when they check in and they sign consent for care, that they are assuming that. I thought that's where we rested with that.
I'm thinking of storm forward visits where it'll be less clear.
I'll loop back with him and ask him about that.
Sean, can I ask a question? Sorry.
Yeah, go ahead.
Sorry. So again, I know this is, we're mostly talking about primary care and consults, but, if you're in an emergency department or you're having a stroke and the standard of care at that emergency department is to get a telestroke consult or, that's the only way you can have immediate access for emergent care. It's not a choice. And so, I don't know, I guess I take issue with you have chosen to receive. If we're talking
if
about
your patient's
broad
unconscious, yeah,
Right.
or hemiplegic, can't talk.
Well, another option too to consider is taking a look at your general consent for care form now and adding that we may be offer, we provide telehealth services that may be available to you, or just something that's embedded within that consent for care when they're signing that. So at least it says that it's, we provide this and it may be a service to you, or some kind of general
but it's still
vague
embedded.
language, but it references telehealth or telemedicine.
I think that would make sense in venue, like in ER, that
Then you don't have
you
to
may or
worry
may
about
not
it.
need to use it, but if it's in that general consent, you're always covered.
Yeah. It's kind of like anything else, and then it's up to the patient to opt out.
Yeah.
And maybe that's the route we want to take. We don't give them direct, counsel on what to say. Check in with your legal department, consider putting this in your general consent. And then it just kind of leaves it wide open for adoption and.
Well, maybe it's a different question that we need to include in here then is, no, there's not any special consent, and we're saying it's a best practice, but now on the fraud prevention side, we're saying, actually, we really do need some sort of statement in there saying how this visit was conducted, which is what your one-liner piece here kind of gets at.
I think
So
we're
that's
talking
now
about.
turning into what we initially defined as a best practice, really, we're turning into, it probably should be just a standard.
Yes.
For coding and billing, no matter which code you're gonna use, we should have, this was a telemedicine visit.
I think we're talking about a statement that frames the visit without necessarily going into the consent. And with regards to the concern about somebody coming with a stroke and not being able to communicate, well, that applies in any practice anyways. You have a consenting procedure, but you apply it. The patient comes collapsed and non-responsive, you're gonna take care of him regardless. So that is not necessarily an issue here. I rather have, as is being suggested here, a statement that frames the rest of my documentation, talking that I have talked to the patient, I inform him, the patient chose to do this, as opposed to having a specific consent.
Yeah.
All right.
Okay, well, we're just a little bit over 12, so maybe we can have a little bit more comments sent to me about how to maybe frame this, and I will loop back again with Adam to make sure this is done right from a legal standpoint. A couple of housekeeping things just to wrap up with are, we're going to take the month of April off because of spring break, and also the ATA meeting is in late April. I do want to do some advertising though, and if you are still hankering for your dose of telemedicine, telehealth, there is the regional Northwest Regional Telehealth Resource Center conference, which is going to be at the Olive 8 in Seattle. Cara, do you want to tell us folks a little bit more about that, when it is and exactly, and who's speaking, things like that?
Sure. So as John says, this is the Northwest Regional Telehealth Resource Center annual conference, and it's going to be in Seattle at the Hyatt Olive 8 Hotel downtown on April 10 through 12. We start out the morning of the 10th, a Monday, with a Telehealth 101 and a Telehealth 102 section. It's a pre-conference workshop. And the 101 is very basic telemedicine. How do you set up a telemedicine program? What do you need to consider? What do you have to think through? What questions should you be asking? The Telehealth 102 addresses more legal and regulatory issues, so it's a little bit deeper dive into it. And then in the afternoon, we go into the regular conference. We have several speakers, including nationally known speakers, as well as folks within the region who are that they're doing. We also have a clinical track and a technical track, and the technical track will be interesting this year because they're offering a telehealth technology lab, a hands-on learning lab, so you can play with the equipment that various vendors have available. So I would encourage you to attend and encourage your colleagues to attend. And I think Priscilla was going to send out the link. The link is nrtrt.org. /registration. It'll take you right to the registration page, and we'll give you more information in detail about the conference.
Great, thanks, Cara. How much is the conference to register?
It is, let's see, the pre-conference workshops are $70. A one-day pass is $180, and the all-day pass is $230, and there's a student pass for $180.
Great, I think that's a really good value. There's about 200, 250 people who come, and they really get some big names in the field of telemedicine. And it's small enough that you can kind of mingle and get to know people. So it's the CME is offered for those folks who are interested in, and that's a really, really good resource. The last thing is on May 5th, we'll have our next meeting, and that's going to be at the University of Washington in our library where we've had it before, and that's from 1 to 3 p.m. If you show up in person, we have photos for you that we'll hand out so you can show your family that you went to the Senate chambers and rubbing shoulders with the movers and shakers. And I think we just have a couple of homework that we'll follow up with folks on. And if there's, maybe just see if there's any last questions or comments before we wrap up.
What was the time again?
So May 5th,
Great.
1 p.m., 1 to 3 p.m. At the University of Washington. Okay, well, great. Thanks, everyone. We'll be sending out the minutes here in a little bit. And thanks, everyone, for coming here in person.